My name is Sara Neches, and I'm one of the Neonatal Fellows at the University of Washington. And today I'd like to share with you my work on the use of premedication for improving outcomes for neonatal intubation. Neonatal tracheal intubation is an important technical skill. However, even highly experienced providers have only average first attempt success. Intubation is not only hard, but it can also be dangerous, with research showing that the adverse effects of failed intubation, including increased intracranial pressure or prolonged hypoxia, may contribute to worse long term developmental outcomes of infants who've had multiple intubation attempts. Many centers use different regimens of intubation premedication based on whether one expects an infant to remain intubated, like in the setting of respiratory failure or a procedure, or if the infant will be immediately extubated, like surfactant delivery using the Ensure technique, where you'd likely avoid a paralytic. It is not known whether there's a greater association with full versus partial premedication on intubation success and intubation adverse events. And this is the question I sought to answer with this project. This is a single center retrospective cohort study using prospectively collected data from the National Emergency Airway Registry for Neonates, or NEAR for NEOS. A premedication recommendation for non emergent intubation was introduced at the University of Washington on May 29, 2019. Full premedication was defined as the sequential administration of a vagolytic, atropine, followed by an opiate, morphine or fentanyl, and then a paralytic medication. Premedication usage varied by epoch as shown in the table below on the right. Data were collected on 207 intubation encounters occurring in the NICU in 133 infants with a median of 29 weeks gestation and birth weight of 1,100 grams. The figure on the upper left shows the rate of tracheal intubation associated events with full premedication compared with no or partial premedication. On the y axis is the number of intubation encounters, while the x axis shows the combined adverse events per intubation encounter. For example, 2 could represent an esophageal intubation immediately recognized and severe bradycardia occurring during one intubation encounter. As you can see, most intubation encounters are uncomplicated. However, the intubations performed with full premedication, depicted in teal, have significantly fewer adverse events per encounter, a compelling argument for the use of full premedication. For the 207 intubation encounters, there were significantly more attempts made when no or partial premedication was used. The use of full premedication was associated with increased success intubating on the first attempt and fewer adverse events. These findings contribute to the debate surrounding use of premedication for non emergent neonatal intubation and will further inform ongoing QI projects to increase utilization rates of full premedication at the University of Washington NICU.